Question 1. Radiation biology. A patient undergoing radiation therapy for lung cancer is experiencing acute side effects, including esophagitis and pneumonitis. These effects are most likely due to A. The deterministic nature of radiation injury, B. Stochastic effects leading to DNA mutations, C. The inverse dose rate effect of fractionation, D. The radioprotective effect of hypoxia. Answer: A. The deterministic nature of radiation injury. Explanation: acute radiation effects, such as esophagitis and pneumonitis, are classified as deterministic effects because they occur at a threshold dose and increase in severity with increasing radiation exposure. These effects are caused by direct cellular damage leading to inflammation and loss of tissue function. Deterministic effects differ from stochastic effects, which refer to radiation-induced mutations that can lead to cancer but do not have a dose threshold. This eliminates option B. The inverse dose rate effect applies primarily to low-dose rate brachytherapy and does not contribute to acute radiation effects, eliminating option C. Hypoxia is known to reduce radiosensitivity in tumors but does not have a radioprotective effect on normal tissue. Side effects, eliminating option D. Relevant guidelines. National Cancer Institute (NCI) guidelines for radiation toxicity grading, TD5, and TD50, tables for organ tolerance doses. Question 2. Imaging in radiation oncology. Scenario-based. Dr. Patel is preparing a treatment plan for a patient with a high-grade glioma. The patient previously had surgery and is now set to receive fractionated radiation therapy. The tumor is near critical structures, including the brainstem and optic chiasm. Dr. Patel must determine the most appropriate imaging modality for precise target delineation. Which of the following should Patel prioritize? A. PET-CT for metabolic tumor assessment, B. MRI with contrast for soft tissue definition, C. kilovolt GET for daily setup verification, D. Plain X-ray for anatomical localization. Answer: B. MRI with contrast for soft tissue definition. Explanation: MRI with contrast is the gold standard for brain tumor delineation as it provides superior soft tissue contrast, allowing precise visualization of tumor margins, peritumoral edema, and involvement of critical structures. PET-CT, option A, is useful for metabolic assessment but is not the primary choice for anatomical target delineation in gliomas. Kilovolt DET, option C, is primarily used for daily image-guided radiation therapy. It gets set up rather than initial tumor delineation. Plain X-ray, option D, lacks the necessary soft tissue resolution for brain tumor planning. Relevant guidelines: Astro-American Society for Radiation Oncology, Brain Tumor Guidelines SEN, National Comprehensive Cancer Network Guidelines for CNS Tumors. Question 3. Radiation Safety and Protection. A radiation oncology department is installing a new high-energy linear accelerator (LINAC) for external beam radiation therapy. According to NRC Nuclear Regulatory Commission and OPM, American Association of Physicists in Medicine, guidelines, what is the most important consideration when designing the radiation shielding for the treatment room? A. The type of fractionation schedule used for patients. B. The energy of the LINAC and workload of the facility. C. The number of patients treated per day. D. The ALARA, as low as reasonably achievable principle. Answer: B. The energy of the LINAC and workload of the facility. Explanation: radiation shielding design must account for the energy of the linear accelerator, MEV range, workload, GIWG, use factor, and occupancy factor of surrounding areas. Option A is incorrect because fractionation schedules do not determine shielding thickness. Option C is a secondary factor as workload is based on overall dose output rather than the number of patients alone. Option D, ALARA principle, is essential for radiation protection but does not define shielding requirements. Relevant guidelines SRP report No. 151, Structural Shielding Design and Evaluation for Megavoltage X. And gamma-ray radiotherapy facilities OPM task group reports on shielding and radiation protection. Question 4. Radiation shielding and facility design. A newly established radiation oncology department is setting up a linear accelerator (LINAC) treatment room. The physicist in charge must ensure that the shielding is adequate to protect patients, staff, and the public from unnecessary radiation exposure. The walls of the room are made of high-density concrete, and additional lead shielding is planned for areas with high radiation leakage potential. The following is the most important factor when determining the necessary thickness of the shielding materials. A. The type of radiation being used and its energy level. B. The number of patients treated per day in the facility. C. The type of flooring material in the treatment room. D. The color and design of the treatment room to reduce patient anxiety. Answer A. The type of radiation being used and its energy level. Explanation. The shielding design in a radiation oncology department is primarily dictated by the energy and type of radiation used. Higher energy radiation, such as photons from a 15 MV LUNAC, requires thicker shielding compared to lower energy radiation like orthovoltage X-rays. Regulatory agencies, including the National Council on Radiation and Measurements (SRP), provide shielding guidelines based on workload, use factor, occupancy factor, and barrier transmission requirements. Option B is incorrect because while the number of patients affects total exposure, it does not directly determine the shielding material's thickness. Option C is incorrect because flooring material does not contribute significantly to radiation attenuation. Option D is incorrect because while room design impacts patient comfort, it has no role in determining radiation shielding requirements. Question 5. Tumor hypoxia and radiosensitivity. Oxygen plays a crucial role in the response of tumors to radiation therapy. A physician treating a patient with a hypoxic tumor is considering different strategies to overcome the reduced radiosensitivity associated with hypoxia. Which of the following statements best explains the effect of hypoxia on radiation therapy and an appropriate strategy to improve treatment effectiveness? A. Hypoxic tumors are more sensitive to radiation, so dose reduction is recommended. B. The oxygen enhancement ratio is lower in well-oxygenated tissues, making them more radioresistant. C. Hypoxia leads to radioresistance and hyperfractionation, or radiosensitizers can improve outcomes. D. The presence of oxygen decreases DNA damage, reducing tumor control probability. Answer. C. Hypoxia leads to radioresistance and hyperfractionation, or radiosensitizers can improve outcomes. Explanation. Tumor hypoxia is a major challenge in radiation oncology. Oxygen is critical for the formation of DNA damage following radiation exposure, and hypoxic tumors, oxygen-deficient tumors, are significantly more resistant to radiation therapy. The oxygen enhancement ratio OA describes how much more effective radiation is in the presence of oxygen. Strategies to overcome hypoxia include hyperfractionation, delivering smaller doses more frequently, hypoxic radiosensitizers, e.g., nimorazole, and hyperbaric oxygen therapy. Option is incorrect because hypoxic tumors are more resistant, not more sensitive, to radiation. Option B is incorrect because OA is higher in well-oxygenated tissues, making them more radiosensitive, not more radioresistant. Option D is incorrect because oxygen enhances DNA damage and tumor control probability rather than decreasing it. Question 6. Scenario-based question. Adaptive radiation therapy in lung cancer. Dr. Patel is treating 65-year-old male patient diagnosed with locally advanced non-small cell lung cancer (SLC). The patient has significant tumor shrinkage during treatment, and the physician is considering an adaptive radiation therapy approach. The original treatment plan was based on 4D scan accounting for respiratory motion, but tumor reduction. Dr. Patel is evaluating possible modification to the treatment plan. Which of the following best describes the potential benefit of ART in this case? A. ART allows for continuous dose escalation to maximize tumor control and minimize normal tissue toxicity. B. ART reduces the need for image-guided radiation therapy and other imaging modalities. C. ART ensures that the treatment plan is adjusted in real time to account for tumor and anatomical changes. D. ART eliminates the need for respiratory gating and motion management techniques. Answer C. ART ensures that the treatment plan is adjusted in real time to account for tumor and anatomical changes. Explanation. Adaptive radiation therapy, ART, is a key advancement in radiation oncology that allows real-time modification of a treatment plan based on tumor and anatomical changes. In lung cancer, tumor shrinkage can occur during therapy, and ART helps refine target volumes, reduce dose to healthy tissues, and improve coverage. Option is incorrect because while dose escalation may be possible, ART does not necessarily aim for continuous escalation. Option B is incorrect because ART often requires more frequent imaging, EET, MRI-based adaptation, to guide treatment modifications. Option D is incorrect because ART does not eliminate the need for respiratory motion management techniques, which remain important for lung cancer treatment. Question 7. Brachytherapy dosimetry and source strength. A radiation oncologist is planning an intracavitary brachytherapy procedure for a patient with cervical cancer. The treatment plan involves high-dose rate HDR brachytherapy using an iridium 192 192 source. Which of the following parameters is most critical in determining the radiation dose delivered to the tumor in this procedure? A. Source activity and dwell time. B. Patient positioning and immobilization. C. The number of fractions prescribed in external beam therapy. D. The patient's age and general health condition. Answer A. Source activity and dwell time. Explanation. In brachytherapy, the radiation dose delivered is primarily determined by the activity of the source, measured in curies or becquerels, and the dwell time, how long the source remains in a given position within the applicator. Treatment planning software calculates optimal dwell positions and times to achieve a conformal dose distribution while sparing healthy tissues. Option B is incorrect because while patient positioning affects external beam therapy, it has minimal impact on dose distribution in brachytherapy. Option C is incorrect because while external beam fractions influence overall treatment, the dose from brachytherapy is independently calculated. Option D is incorrect because patient age and health condition may impact overall treatment decisions but do not directly determine brachytherapy dose. Question 8. Radiation-induced secondary malignancies. A 45-year-old breast cancer survivor who underwent radiation therapy 15 years ago is diagnosed with a secondary malignancy in the same region. Which of the following is the most likely explanation for this occurrence? A. The patient's age at the time of initial treatment increased the risk of secondary cancer. B. Radiation therapy only affects cancerous tissues and does not contribute to secondary malignancies. C. The linear quadratic model predicts an inverse relationship between dose and secondary malignancy risk. D. Secondary malignancies only occur in patients who received chemotherapy in combination with radiation therapy. Answer A. The patient's age at the time of initial treatment increased the risk of secondary cancer. Explanation. Radiation-induced secondary malignancies are known stochastic effect of radiation therapy. The risk is higher in younger patients because their longer life expectancy provides more time for radiation-induced DNA damage to manifest as cancer. Option B is incorrect because radiation affects both normal and cancerous tissues, and secondary malignancies are well-documented long-term risk. Option C is incorrect because the linear quadratic model describes cell survival, not secondary cancer risk. Option D is incorrect because secondary cancers can arise from radiation alone, though chemotherapy can further increase risk. Question 9. Image-guided radiation therapy, IGIT, and treatment margins. A 58-year-old patient is receiving intensity-modulated radiation therapy, IMIT, for prostate cancer. The treatment team is using daily cone beam computed tomography (EET) for image-guided radiation therapy, IGIT, to improve localization accuracy. Which of the following best describes how IGIT affects treatment margins? A. IGIT allows for margin reduction, improving normal tissue sparing while maintaining tumor coverage. B. IGIT eliminates the need for treatment margins because the tumor position is precisely identified each day. C. IGIT increases treatment margins to account for daily anatomical variations and ensure tumor coverage. D. IGIT has no impact on treatment margins as they are determined solely by tumor biology. Answer A. IGIT allows for margin reduction, improving normal tissue sparing while maintaining tumor coverage. Explanation. IGIT enables precise imaging just before or during treatment, reducing setup errors and organ motion uncertainties. This allows for smaller treatment margins, reducing radiation exposure to nearby healthy tissues while maintaining accurate tumor coverage. Option B is incorrect because even with IGIT, small setup errors and motion uncertainties exist. Option C is incorrect because IGIT is used to decrease, not increase, treatment margins. Option D is incorrect because treatment margins depend on multiple factors, including imaging accuracy, not just tumor biology. Question 10. Stereotactic radiosurgery, SRS, in brain metastasis. A 47-year-old patient with non-small cell lung cancer, SLCR, develops a single 3 cm brain metastases in the right parietal lobe. The radiation oncology team recommends stereotactic radiosurgery, SRS, instead of whole brain radiation. But which of the following best explains the advantage of SRS in this case? SRS delivers high-dose radiation to the tumor while sparing surrounding brain tissue, reducing cognitive decline. But SRS is a form of systemic therapy that treats cancer cells throughout the body. C. SRS requires daily treatments over several weeks, improving overall treatment response. D. SRS is only used when there are multiple brain metastases, not for solitary lesions. Answer A. SRS delivers high-dose radiation to the tumor while sparing surrounding brain tissue, reducing cognitive decline. Explanation: SRS is a highly precise high-dose radiation treatment that is particularly beneficial for single or small numbers of brain metastases. Anebura, which treats the entire brain. SRS targets the tumor while sparing normal tissue, reducing the risk of cognitive side effects. Option B is incorrect because SRS is a localized treatment, not a systemic therapy. Option C is incorrect because SRS is typically delivered in 1/5 fractions, hypofractionation, not over several weeks. Option D is incorrect because SRS is effective for single lesions as well as limited metastasis oligostatic disease. Question 11. Radiobiology and the 4 R's of radiation therapy. Radiation therapy is governed by 4 fundamental principles known as the 4 R's of radiobiology: repair, redistribution, repopulation, and reoxygenation. Which of the following best describes the role of reoxygenation in fractionated radiation therapy? A. Reoxygenation enhances radiosensitivity by increasing oxygen availability in previously hypoxic tumor cells. B. Reoxygenation allows tumor cells to recover from sublethal radiation damage between fractions. C. Reoxygenation increases repopulation of tumor cells, making radiation therapy less effective. D. Reoxygenation has no impact on radiation therapy outcomes and is not a relevant factor. Answer A. Reoxygenation enhances radiosensitivity by increasing oxygen availability in previously hypoxic tumor cells. Explanation: hypoxic tumor cells are more resistant to radiation. However, during fractionated therapy, hypoxic regions may become better oxygenated, reoxygenation increasing their radiosensitivity in subsequent fractions. Option B is incorrect because repair, not reoxygenation, is responsible for recovery from sublethal damage. Option C is incorrect because repopulation refers to cancer cell growth, not oxygen availability. Option D is incorrect because reoxygenation is a key mechanism in radiation therapy. Question 12. Proton therapy and relative biological effectiveness. A pediatric patient with a brain tumor is being considered for proton therapy instead of conventional photon therapy. One of the key advantages of proton therapy is its unique dose distribution and relative biological effectiveness. How does RBE impact treatment planning for proton therapy? A. Proton therapy has a higher RBE compared to photons, requiring dose adjustments to maintain biological effect. But RBE is irrelevant in proton therapy because protons deliver energy uniformly like photons. C. RBE increases with increasing proton energy, making high-energy beams less effective. D. Proton therapy eliminates the need for fractionation due to its superior biological effectiveness. Answer A. Proton therapy has a higher RBE compared to photons, requiring dose adjustments to maintain biological effect. Explanation: protons have a higher RBE 1.1 compared to photons 1.0, meaning they are slightly more effective per unit dose. This must be accounted for in treatment planning to avoid overdosing normal tissues. Option B is incorrect because protons deposit energy differently from photons, especially at the Bragg peak. Option C is incorrect because RBE can increase near the end of the proton track, Bragg peak region. Option D is incorrect because fractionation is still used in proton therapy. Question 13. Radiation safety and the ALARA principle. A radiation therapist is working in a facility that performs high-dose rate HDR brachytherapy. To minimize exposure, they follow the ALARA, as low as reasonably achievable, principle. Which of the following actions best follows ALARA guidelines? A. Using shielding, minimizing exposure time, and increasing distance from the radiation source. B. Wearing a personal dosimeter only when handling radioactive sources. C. Standing near the patient for the entire duration of HDR brachytherapy to monitor dose delivery. D. Holding the radioactive source directly to verify its strength before patient treatment. Answer A. Using shielding, minimizing exposure time, and increasing distance from the radiation source. Explanation: the ALARA principle is based on 3 key strategies. Time: minimize time spent near the radiation source. Distance: maximize distance from the source. Shielding: use lead barriers, walls, and protective gear. Option B is incorrect because personal dosimeters should be worn at all times in radiation environment. Option C is incorrect because standing near the patient increases unnecessary exposure. Option D is incorrect because sources should be handled with remote afterloading systems, not manually. Question 14. Dose constraints for organs at risk in head and neck radiation therapy. A 63-year-old patient with oropharyngeal cancer is undergoing intensity-modulated radiation therapy into a total dose of 70 Gy in 35 fractions. The spinal cord, parotid glands, and brainstem are critical organs at risk in the treatment plan. Which of the following dose constraints is most appropriate? Spinal cord to minimize the risk of radiation myelopathy. A. Maximum S equals 45 Gy. B. Minus equals 45 Gy. C. Maximum S equals 60 Gy. E equals 60 Gy. Answer A. Maximum S equals 45 Gy. Explanation. Radiation myelopathy is serious complication of spinal cord irradiation. The accepted dose constraint for the spinal cord in fractionated radiation therapy is maxima S equals 50 Gy. Significantly increase the risk of permanent spinal cord injury. Option B is incorrect because dose constraints for the spinal cord focus on maximum dose, not mean dose. Options C and D are incorrect because 60 Gy far exceeds safe limits for the spinal cord. Question 15. Hypofractionation in prostate cancer treatment. A 72-year-old patient with low-risk prostate cancer is considering moderate hypofractionation as an alternative to conventional fractionation. Instead of receiving 7880 Gy in 3940 fractions, E is prescribed 60 Gy in 20 fractions. What is the primary radiobiological advantage of hypofractionation in prostate cancer? A. Prostate cancer has low Ib ratio, making it more sensitive to larger fraction sizes. B. Hypofractionation increases total dose, improving local control. C. Hypofractionation allows faster reoxygenation of hypokick tumor cells. D. The Ab ratio of prostate cancer is higher than normal tissues, reducing late toxicity. Answer A. Prostate cancer has a low Ab ratio, making it more sensitive to larger fraction sizes. Explanation. The Ab ratio of prostate cancer is low, approximately 1.5 Gy, similar to late-responding normal tissues. This means prostate tumors respond well to larger fraction sizes, which deliver higher biologically effective doses. Option B is incorrect because hypofractionation lowers the total dose but maintains effectiveness through bed adjustments. Option C is incorrect because reoxygenation is not the primary mechanism behind hypofractionation. Option D is incorrect because prostate cancer has lower Ab ratio than surrounding normal tissues. Question 16. Radiopharmaceuticals in targeted therapy. A patient with metastatic castration-resistant prostate cancer (RC) is being considered for treatment with lutetium-177 Lu-177 PSMA therapy. What is the primary mechanism by which Lu-177 PSA therapy targets and destroys cancer cells? A. Lu-177 binds to prostate-specific membrane antigen (PSA) and emits beta particles that induce DNA damage. B. Lu-177 releases alpha particles that selectively kill circulating tumor cells in the bloodstream. C. Lu-177 acts as a radiosensitizer, making external beam radiation therapy more effective. D. Lu-177 only enhances imaging and does not contribute to therapeutic effects. Answer A. Lu-177 binds to prostate-specific membrane antigen PSMA and emits beta particles that induce DNA damage. Explanation. Lu-177 is a beta-emitting radiopharmaceutical that binds to PSMA, a protein highly expressed on prostate cancer cells. Once bound, Lu-177 emits beta particles that cause double-strand DNA breaks, leading to cell death. Option B is incorrect because Lu-177 primarily emits beta particles, not alpha particles. Option C is incorrect because Lu-177 is a therapeutic agent, not a radiosensitizer. Option D is incorrect because Lu-177 has both diagnostic, imaging, and therapeutic applications. Theranostics. Question 17. Image verification in stereotactic body radiation therapy. A patient with a 5 cm lung tumor is receiving stereotactic body radiation therapy (SRT) to 54 Gy in 3 fractions. The radiation oncology team uses 4 CT and EET to verify tumor position before treatment. Why is forward CT imaging essential in SRT? A. 4 CT accounts for tumor motion due to respiration, ensuring accurate treatment planning. B. Forward CT increases total treatment dose to compensate for tumor hypoxia. C. Forward CT removes the need for image guidance during treatment sessions. D. Forward CT is used only for brain tumors, not lung tumors. Answer A. Forward CT accounts for tumor motion due to respiration, ensuring accurate treatment planning. Explanation: in LIS-RT, tumors move with respiration, which can lead to dose inaccuracies. Forward CT captures the tumor's movement throughout the breathing cycle, allowing precise targeting and appropriate motion management strategies, e.g., gating or breath hold techniques. Option B is incorrect because forward CT does not change the prescribed dose. Option C is incorrect because image guidance, DET, is still required before each treatment session. Option D is incorrect because forward CT is specifically used in thoracic and abdominal tumors. Question 18. Adaptive radiation therapy in head and neck cancer. A 59-year-old patient with nasopharyngeal carcinoma is receiving chemoradiation with IMA. By week 4 of treatment, tumor shrinkage and weight loss caused noticeable anatomical changes. How does adaptive radiation therapy improve treatment accuracy in this scenario? A. Modifies the treatment plan mid-course based on anatomical and tumor changes. B. Increases the prescribed radiation dose to compensate for tumor shrinkage. C. Eliminates the need for daily image guidance during treatment. D. Is only useful for palliative radiation, not curative treatment. Answer A. Modifies the treatment plan mid-course based on anatomical and tumor changes. Explanation: adaptive radiation therapy allows for replanning of treatment based on tumor shrinkage, weight loss, or organ movement. This ensures the radiation dose remains accurately targeted while sparing normal tissues. Option B is incorrect because does not automatically increase dose but adjusts dose distribution. Option C is incorrect because daily image guidance is still necessary. Option D is incorrect because is widely used in curative treatments, particularly for head and neck cancers. Question 19. Dose escalation in head and neck cancer. A 58-year-old patient with locally advanced oropharyngeal squamous cell carcinoma (TASH positive) is prescribed IMiT with concurrent chemotherapy. The standard fractionation schedule delivers 70 Gy in 35 fractions. However, a new clinical trial investigates dose escalation to 84 Gy in 42 fractions. Which of the following is the greatest potential of dose escalation in this scenario? A. Increased risk of late complications such as osteoradionecrosis of the mandible. B. Increased likelihood of tumor hypoxia and radioresistance. C. Higher incidence of treatment-related infections. D. Reduced probability of tumor control due to lower biologically effective dose bet. Answer A. Increased risk of late complications such as osteoradionecrosis of the mandible. Explanation: dose escalation increases late toxicity to critical structures like the mandible, pharyngeal muscles, and salivary glands. Osteoradionecrosis is a major concern at doses 70 Gy. Option B is incorrect because dose escalation does not promote hypoxia. Rather, tumor hypoxia is a challenge in general. Option C is incorrect because radiation therapy itself does not directly increase infection rates. Option D is incorrect because high dose generally improves tumor control, not reduces it. Question 20. Image-guided radiation therapy in prostate cancer. A patient with intermediate-risk prostate cancer is undergoing hypofractionated IMiT, 60 Gy in 20 fractions, with daily image guidance. Which of the following image-guided radiation therapy techniques is most appropriate to manage prostate motion? A. Fiducial marker-based can be A. Breath hold technique using force CT. C. Surface-guided radiation therapy alone. D. Immunorenal treatment planning without it. Answer A. Fiducial marker-based can be explanation. The prostate can move due to rectal and bladder filling, requiring fiducial markers per CET for precise localization. Option B is incorrect because breath hold is more relevant for thoracic abdominal tumors, not the prostate. Option C is incorrect because RT alone cannot accurately track deep-seated tumors like the prostate. Option D is incorrect because immunorenal planning does not replace IGA. Question 21. Guided radiation therapy advantages. Guided radiation therapy offers real-time soft tissue imaging during treatment. Which of the following is a primary advantage compared to conventional IGAT? A. Improved visualization of soft tissue structures without additional radiation dose. B. Shorter treatment time per fraction compared to guided treatment. C. Less need for adaptive radiation therapy due to stable tumor anatomy. D. Superior visualization of bone structures compared to CT-based imaging. Answer A. Improved visualization of soft tissue structures without additional radiation dose. Explanation: RT provides real-time tumor tracking without extra ionizing radiation. Option B is incorrect because MRT treatments are often longer due to imaging and adaptation. Option C is incorrect because RT actually facilitates adaptive planning. Option D is incorrect because ET provides better bone detail than MRI. Question 22. Stereotactic radiosurgery (SRS) for brain metastases. A patient with forebrain metastases from lung cancer is scheduled for stereotactic radiosurgery (SRS). Which of the following factors most strongly supports choosing SRS over whole brain radiation? Improved neurocognitive function preservation. B. Shorter treatment time compared to B. C. Low cost. B. D. Increased extracranial tumor control. Answer A. Improved neurocognitive function preservation. Explanation: SRS spares normal brain tissue, reducing cognitive decline compared to B. Option B is incorrect because SRS requires complex planning, often taking longer per session. Option C is incorrect because SRS can be more expensive. B. Option and D is incorrect because SRS only treats intracranial disease. Question 23. Motion management in La SRT. A patient with a 3 cm lung tumor is planned for SRT 50 GI in 5 fractions using gated radiation delivery. What is the primary benefit of respiratory gating in this setting? A. Reducing target volume margins and sparing normal lung tissue. B. Increasing radiation dose per fraction for better tumor control. C. Shortening overall treatment time. D. Eliminating the need for image guidance during treatment. Answer A. Reducing target volume margins and sparing normal lung tissue. Explanation: respiratory gating tracks tumor motion and reduces the need for large PTV margins, improving normal tissue sparing. Question 24. Adaptive radiation therapy for bladder cancer. A 65-year-old male with muscle-invasive bladder cancer (TERNMEM) is undergoing bladder-preserving chemoradiotherapy with adaptive radiation therapy The treatment plan involves daily EET-based to adjust for bladder volume changes. Which of the following is the primary advantage of in this scenario? A. Reducing unnecessary radiation to adjacent normal tissues by adjusting for daily bladder volume variations. B. Shortening overall treatment time by reducing the number of fractions. C. Increasing the effectiveness of concurrent chemotherapy. D. Improving tumor hypoxia to enhance radiation sensitivity. Answer A. Reducing unnecessary radiation to adjacent normal tissues by adjusting for daily bladder volume variations. Explanation: bladder size and shape vary daily, requiring to minimize toxicity to normal tissues like the rectum and bowel. Option B is incorrect because does not inherently shorten treatment. Option C is incorrect because chemotherapy effectiveness is not directly improved by Option D is incorrect because does not alter tumor oxygenation directly. Question 25. Proton therapy in pediatric brain tumors. A 10-year-old child with medulloblastoma is receiving craniospinal irradiation (CSI) using proton therapy. What is the main advantage of proton therapy in this case? A. Reduced dose to developing organs, minimizing long-term toxicities. B. High tumor control probability due to superior linear energy transfer (LET). C. Low risk of radiation-induced nausea compared to photon therapy. D. Ability to eliminate the need for anesthesia during treatment. Answer A. Reduced dose to developing organs, minimizing long-term toxicities. Explanation: proton therapy has a Bragg peak, meaning less exit dose to growing tissues, reducing neurocognitive and endocrine toxicities. Option B is incorrect because proton therapy has a similar LET to photons, not higher. Option C is incorrect because nausea is not directly dependent on the radiation modality. Option D is incorrect because young children still require anesthesia for immobilization. Question 26. Stereotactic body radiation therapy (SRT) in liver tumors. A 72-year-old patient with hepatocellular carcinoma (HCC) unsuitable for surgery is treated with SRT 50 GI in 5 fractions. What is the greatest challenge in delivering SRT to liver tumors? A. Managing respiratory motion during treatment. B. Achieving sufficient dose escalation without toxicity. C. reducing dose to the heart and great vessels. D. Limiting systemic side effects of radiation. Answer A. Managing respiratory motion during treatment. Explanation. Liver tumors move with respiration, requiring forward CT, breath hold, or fiducial tracking to minimize PTV expansion. Option B is incorrect because 50 Gi in 5 fractions is already a high ablative dose. Option C is incorrect because the primary concern is sparing normal liver tissue, not necessarily the heart. Option D is incorrect because systemic side effects are minimal with Asota. Question 27. Radiobiology of hypofractionation. A patient with early-stage prostate cancer is receiving ultrahypofractionated imity, 36.25 Gi in 5 fractions, instead of conventional fractionation. Which of the following best explains the rationale for hypofractionation in prostate cancer? A. Prostate cancer has a low Ab ratio, making it more sensitive to larger fraction sizes. B. Hypofractionation reduces late toxicity to surrounding organs. C. Prostate cancer cells recover more slowly between fractions, improving tumor control. D. Large dose per fraction reduces the likelihood of radioresistant subclones. Answer A. Prostate cancer has a low Ab ratio, making it more sensitive to larger fraction sizes. Explanation. Prostate cancer has an Ab ratio of 1.5, meaning it responds better to higher doses per fraction. Option B is incorrect because hypofractionation increases the risk of late toxicity. Option C is incorrect because prostate cancer does not have slow repair kinetics than normal tissue. Option D is incorrect because radioresistant subclones are not the primary concern in prostate cancer. Question 28. Reirradiation considerations in head and neck cancer. A 60-year-old patient previously treated with 70 Gi for oropharyngeal carcinoma now presents with a local recurrence. The team considers reirradiation using imity 60 Gi in 30 fractions. Which of the following is the most significant risk of reirradiation? A. Severe late toxicity, including carotid blowout syndrome. B. Decreased tumor control due to prior radiation resistance. C. Increased risk of radiation recall syndrome. D. Higher probability of metastatic disease after reirradiation. Answer A. Severe late toxicity, including carotid blowout syndrome. Explanation. Reirradiation increases risk of vascular damage, leading to carotid rupture, carotid blowout syndrome. Option B is incorrect because prior radiation does not necessarily induce resistance. Option C is incorrect because radiation recall is linked to chemotherapy, not reirradiation. Option D is incorrect because reirradiation does not increase metastatic risk. Question 29. Total skin electron therapy set in mycosis fungoides. A 55-year-old patient with extensive cutaneous T-cell lymphoma, mycosis fungoides, stage I, is undergoing total skin electron therapy set at 36 Gi in 24 fractions. What is the most common acute toxicity associated with SET? A. Erythema and dry desquamation. B. Severe nausea and vomiting. C. Permanent alopecia. D. Bone marrow suppression. Answer A. Erythema and dry desquamation. Explanation. SET causes skin reactions. Erythema dry with desquamation due to high surface dose deposition. Option B is incorrect because SET does not significantly affect the GI tract. Option C is incorrect because hair regrows after SET. Option D is incorrect because electrons do not penetrate deep enough to affect bone marrow. Question 30. Tumor hypoxia and radiation resistance. A patient with cervical cancer undergoes EBA with concurrent cisplatin chemotherapy. Hypoxia is suspected based on functional PET imaging. Which of the following is the most effective strategy to overcome hypoxia-related radiation resistance? A. Increasing radiation dose with dose painting techniques. B. Using standard fractionation, 2 Gi per fraction, to allow reoxygenation. C. Adding a hypoxia modifier such as nimorazole. D. Switching from photon-based IMiT to proton therapy. Answer C. Adding a hypoxia modifier such as nimorazole. Explanation. Hypoxia sensitizers e.g. nimorazole, toropazamine enhance radiation response in hypoxic tumors. Option is incorrect because dose escalation alone does not resolve hypoxia-related resistance. Option B is incorrect because reoxygenation happens mainly with altered fractionation, not standard fractionation. Option D is incorrect because proton therapy does not inherently overcome hypoxia.